we all being good gentlemen, we call the lady first, Utkarsha.
Should I begin? Yes, a very good afternoon. I'll be speaking briefly on management of acute ankle inversion injuries in our OPDs. Our objectives are to understand the inversion injuries of the ankle, how to perform a detailed evaluation of the patient, and then providing specific treatment. So acute ankle sprains present very commonly in all our OPDs. And of all the injuries around the ankle, 75% are ligament sprains. 85% of these sprains are inversion injuries, which affect the lateral ankle ligament complex. Of late, there has been a rise in incidence in these injuries as physical activity has become a popular lifestyle choice, and individuals with previously low level of activities are now prepping up for high-intensity workouts, probably popularizing the weekend athletes. So the lateral ligament complex of the ankle consists of the anterior talofibular ligament, the calcaneofibular, and the posterior talofibular ligament. Of these, ATFL is involved in 75% of the sprains, 20% involve both the ATFL and the CFL, and the PTFL, being the strongest among the three, is rarely injured. There are a multitude of intrinsic and extrinsic factors which predispose the patient to ankle sprains. So the ankle in plantar flexion with the foot in inversion leads to an ATFL injury, and the ankle in dorsiflexion and the foot in inversion leads to a CFL injury. The sequence of events is as follows, with the ATFL the most prone to being injured, followed by the capsule, the distal tibiofibular ligament, the CFL, and finally the PTFL. So how do we evaluate a patient in our OPD? With the basic triad of history, examination, and investigations. History should include the mode of injury, whether a tearing sensation or a pop was felt by the patient, whether the patient was able to walk after the injury, any instability, and any similar episodes in the past. For clinical examination, look for swelling and ecchymosis on the lateral aspect of the ankle, palpate for tenderness along the ligamentous attachments, assess the ankle movements active as well as passive, although they may often be painful and restricted, and rule out associated injuries to the syndesmosis, the deltoid, the peroneus, the proximal fibula, the fifth metatarsal base, the tarsal joints, and nerves. So ankle sprains are broadly graded as grade 1 is only stretch of the ligament, 2 involves a partial tear with moderate swelling, and 3 involves a complete rupture of the ligament with significant swelling and instability of the joint. We have a few special tests like the anterior drawer test to assess the integrity of the ATFL. If the talus is displaced forward more than 1 centimeter or 4 millimeters as compared with the opposite side, it is considered positive. And the integrity of the CFL is assessed by the talar tilt test, which is considered positive if there is more than 5 degrees tilt as compared with the other side. But these are often false negative due to pain. So clinical examination may not always provide us with a reliable, complete information. So we need to resort to investigations like X-rays. According to the Ottawa ankle rules, if there is tenderness along the malleoli or inability to bear weight, we perform a AP lateral and mortise views of the ankles. And also, if there's a tenderness at the navicular and along the fifth metatarsal base, we perform a AP lateral and oblique views of the foot to rule out any associated injuries. Ultrasound is an effective complementary tool for primary evaluation of ankle ligamentous injuries, and dynamic ultrasound often recommended to determine the actual disruption of the ligaments. So this is the normal ATFL. If there's a partial tear or a sprain, there is a thickening and a hypoechogenicity of the affected ligaments as seen in grade 1 and 2. In a complete tear, there is an anechoic or a hypoechoic gap extending across the ligament, or often there is a loss of continuity of the ligament. It helps to assess avulsions as well as CFL injuries. MRI is not a part of our routine investigation protocol, but it is indicated if there is a persistent pain for 8 to 10 weeks, recurrent ankle sprains, and to rule out more extensive injuries like syndesmosis, osteochondral lesions, or a midfoot injury. So treatment. The first initial phase consists of rest, ice application, compression, elevation, supplemented with analgesic and anti-inflammatory medications, This often provides significant relief to the patient in the first 48 to 72 hours. We then begin with protected weight bearing for a period of 2 to 3 weeks. This can be done with a semi-rigid brace or ankle strapping. The aim is to limit hindfoot inversion, prevent uncontrolled stresses, and allow protected ankle motion. This is often sufficient in grade 1 and 2 sprains. A short-term immobilization is necessary for grade 3 sprains with severe pain and swelling, or if there's a small undisplaced avulsion fracture, or often if there are complex injuries. Surgery is indicated only when there are recurrent sprains, chronic instabilities, extensive injuries, displaced avulsions, or in athletes who need to get back to their sports earlier. This will be discussed in the next lecture. Rehab forms the crux of conservative management of ankle sprains. It involves restoring the range of motion, followed by muscle strengthening to combat recurrent injuries, proprioception to retrain the injured nerve fibers, and then training for specific activities. So most patients recover completely with the conservative management through 3 phases, and often grade 1 sprains recover in 2 weeks, grade 2 take around 6 weeks, and grade 3, if treated conservatively, do well by about 20 to 26 weeks. Only 20 to 40% develop chronic pain and instability. So our take-home message is a detailed evaluation of acute ankle inversions in our OPDs is a must. Conservative management provides satisfactory outcomes in majority. There should be an emphasis on prevention of future injury and mitigation of long-term effects like chronic instability and arthritis. Surgery, although important, has a limited role. Thank you.
Audience can ask the questions now.
Any questions? Like we have a few minutes so that.
Yes, sir.
On an anterior draw test, how do you assess a 4 mm or 5 mm displacement?
So it is just clinically based on our assessment. It is not possible to measure actually, but if you compare to the contralateral side and if you feel there is a significant displacement, only then we consider it positive. That is why we often supplement our clinical investigations with
So in a grade 1 or 2, you don't get that much instability?
Yes, sir. It is definitely not
So
possible
that
often to
anterior draw is
assess.
not,
It is not a reliable test.
In conservative management in eversion injury, what about the role of eversion stirrup?
So I have no experience with a stirrup.
No, we can use a stirrup brace. So what does the stirrup brace do is like it prevents the subtalar range and gives it adequate immobilization to any subsequent inversion forces. So stirrup is used. So it is as good as, like it's like a mobile way of putting a cast. In a cast, you can't apply regular footwear or something. With a stirrup, you can slide your foot into your regular footwear and still be mobile.
Nice talk. Is there any indication for an acute repair?
So we do not normally go in for an acute repair. We give time for a conservative trial, and if there is recurrent instability or if the patient has persistent pain, only then we go for surgery.
So I would like to add, yes, there is a role for acute repair in a high individual, say like a high individual athlete or a high demand individual athlete in whom that conservative trial is, they are not ready to wait. So for someone who's like after 6 weeks, he doesn't want to wait and watch. And after 6 weeks, again, another 3 months of rehab, in those to bypass that time frame, yes, acute repair.
And quickly just repair the ligament or?
That's the next talk. I will come to that. I will definitely come to that. Yeah, Nikhil?
Last question.
Ecchymosis and rest of the all clinical tests are subjective for
Yes.
diagnosis, right? So in a clinic, how do you diagnose that? Are there any dynamic tests? What I recollect was one of them was a pivot shift. In a standing position, do a pivot test, and if you are able to reproduce the pain on the lateral side, that is the one which is the diagnostic test. And second was put a crepe bandage around the ankle, above the syndesmosis, and make the patient walk. If they are able to if they are able to if the pain is reproducible, probably these are the only two diagnostic tests clinically.
Sangeet sir, I think,
Any view on that?
I think both these tests, especially a single leg hop or a pivot,
For a anterior inferior tibiofibular
yes,
ligament.
anterior.
Yeah.
It's for a
Yeah.
high ankle sprain.
Yeah, high
Yes.
ankle sprain.
And I think Utkarsha spoke on the low ankle sprain.
Okay.
I think we have subsequent talks on deltoid and
Syndesmosis.
syndesmosis, where all these things will be taken.
But the diagnosis is all subjective and it will vary from surgeon to surgeon in a clinic.
Correct, sir. It's like a knee instability, someone who can elicit a Lachman versus someone who feels it is a mushy endpoint.
Madam, in which case you will apply crepe bandage, plaster cast, or walker boot?
So if there's a significant amount of swelling, then we apply a plaster, that is just a slab, and we wait till the swelling subsides because it's difficult to evaluate the grade of sprain and significant swelling.
But
So-
the patient is not willing for the cast, plaster, then
So then we keep them non-weight bearing and then ask them to keep the limb elevated and wait till the swelling subsides and then re-evaluate them.
but not crepe bandage to be applied.
Yes, so if they are not willing for a plaster, then we apply a crepe bandage, but we keep them non-weight bearing and ask them to come for follow-up, re-evaluate them after the swelling subsides.
I think last question, you can stop, you can ask next time. Dr. Abhishek Kini can start.
Hello.
Next topic.
I'm Dr. Deepak. I'm just PG student. I have one question that one patient is there, he's having some ankle swelling. Okay. That ankle swelling is subsided, but the patient is having just ankle swelling after at the evening time only. MRI, CT, everything is normal.
Okay.
So we apply a crepe bandage, everything, but patient is having pain. Okay, so how will manage such a kind of patients? We can't operate because nothing is there. CT is also normal, then MRI is also normal. So how will you
But
proceed
this
with this
is
patient?
how many days after the injury?
This is 4 months.
I'm sorry?
4 months.
4 months. Then we need to evaluate in detail. So it is
Already
not
evaluated, MRI is also normal. Everything is also normal. This patient is having swelling.
Okay, I think that's a little complex patient who I think is heading towards a complex regional pain syndrome. You need to assess him right from history onwards. I think we can talk on this in the tea break.
Okay.
Coming next on ankle instabilities and repairs are butter besides the bread. Ashish, slide. So we take, I think, 3 or 4 questions only because it's a very hot topic. So I think Utkarsha has covered well the ligaments, they are lateral. What is functional instability of the ankle? It's occurrence of frequent sprains, difficulty in doing activities that they expect them to do, say like a running on uneven surfaces, cutting, jumping activities, and recurrent giving way at the end of at least 6 months despite adequate non-surgical therapy. This statement applies to mere mortals like us who are very office goers, just cross the road, sit in the car and come to clinics. Otherwise, in an athlete, it's a different animal that we treat. Most common injury, as we know, is a lateral ligamentous injury and it's an inversion injury. History, proportional to the extent of ligamentous injury, you will have twisting, everything, inability to bear weight. Examination, we know what all things. Also check, most important, as I think one of the doctors were asking, Drawers test, wait for 2 or 5 days for injury. Slight plantar flexion, stabilize the hind foot and tibia. More than 5 millimeters is pathologic, but can vary from 2 to 9 millimeters. So it's a wide range. How do you compare it? Compare it with the opposite side. So someone who is as hyperlax as I am, mine 7 millimeters is like a normal, as compared to someone who is like a very stiff guy, would be like 2 millimeters might be pathologic. So you stabilize the hind foot, stabilize the tibia and pull it anteriorly and slightly rotate it inward. So you will see ATFL being stretched. You will see a small puckering happening over here. That means that's the suction of the capsule into the joint. This is a Drawers test. So another test for CFLs is the varus test. You can do inversion with patient supine, relax the gastroc by knee flex. There is no firm endpoint. Again, the tilt varies in a big range, 0 to 23, compare it with the normal. Important points to evaluate in a recurrent ankle sprains are standing x-rays. Look for the calcaneum, look for the varus of the hind foot. That's like a genu varus with an ACL and a PLC. So you need to address the bony structure also along with the soft tissues. That's the alignment view. Look for other missed injuries like lateral process of talus, anterior process of calcaneum. That could be one of that questions that could learn. There's something else over there. Talus tilt. Not always consistent indicator of functional instability. Like these things can vary on people to people depending on the pain threshold. You do need to evaluate further for loose bodies like a CT scan, osteochondral injuries, MRIs to check all the ligaments in place, sometimes stress fractures happening. This what. So we do an MRI if patients are not improving at around 10 weeks. Certain imaging, like just to complete the talk, capsular damage, arthrography or bone scans to find out if there are any other bone specializers. Management, cast immobilization, functional rehab and operative repair. Brief, like even though Utkarsha has touched on it, the rehab depends on your everter strengthening because that's the outer structure which dynamically stabilizes the ankle. So it's the peroneal tendons and the peroneal muscle groups that are strengthened to bring that evasive ways of action to stabilize your ankle back again on an inversion force. So when will you repair? One of the indicators are if there is a peroneal tendon split, that means already the tendon complex is damaged, and if you ask them to do more rehab, there would be more synovitis, more pain, and that patient is not going to be amenable for functional rehab, conservative. So operative repair, more than 3 episodes, anatomically variations like peroneal tendon repairs, osteochondral injuries, loose bodies. In acute, we do it in high demand athlete with associated injuries like Freddie underwent this, eventually couldn't come back to cricket. Repair, we do a modified Brostrom Gould reconstruction, and in reconstructions like in chronic cases, we do like a free tendon graft like how an ACL is done using a semitendinosis or even a plantaris. So again, coming back to the definition, instability of the ankle, recurrent sprains, recurrent inability to assume activities of daily living despite a relative conservative approach. And again, repair versus reconstruction. Repair is to restore. Reconstruction is to reconstruct something like action or process of being reconstruction, being like adding something new to do something else which is not deemed, say like a ACL or like an ATFL, CFL reconstruction. Modified Brostrom Gould, it's an anatomic repair for ATFL and CFL and with double-breasted of all those tendons. You reinforce, that's the Gould's modification, reinforce with an inferior extensor retinaculum. It can be done open versus arthroscopic. And in reconstruction, this is how it's done. You use a free tendon graft and you reattach to anatomical points of ATFL and CFL. Again, this can be done open and arthroscopic. So repair is easier. Its primary cases, low morbidity, good, excellent results, cost is low. Reconstruction, I do it in revision cases. It's challenging. It has a higher morbidity because you need to harvest the gracilis sometimes. Excellent results, again, cost is high because of more anchors, more implants in anterior. All conclusions for repair versus reconstruction show that the outcomes are almost the same. So you need to be sure what works good in your hands and do appropriate cases so that the patient is like getting good results. So they have a distinct role, both repairs and reconstruction. I do repairs primarily, reconstructions are offered in revision cases. And again, open or arthroscopic is just a way of performing this surgery. So coming back to the same drawers, the lax ATFL, this, if you see this ATFL was deficient over here. So what we've done is we do an arthroscopic repair. This is the bare footprint which is kind of, you see, look at the previous slide. The ATFL has come out from the footprint over here. So this is the footprint. You use suture passing techniques, pass it through this is the ATFL and the inferior extensor retinaculum. And then as you tie the knot, it's like how you do a Bankart's repair, or how sir has been doing a Bankart's repair. You get the whole capsulo-ligamentous complex back attached onto the footprint. And this is what it is. On table drawers is negative. Again, things not to miss in an ankle sprain: proximal fibula fractures, lateral process of talus, that's the snowboarder's fractures, anterior process of calcaneum, Yuvraj Singh had one and was missed. Lisfrank's injury, as we have just seen in the previous session, it can be missed. Tendon injuries like peroneus brevis splits or peroneal tendon subluxations can also mimic lateral instability. Thank you. Any questions? Quick questions? Yes, sir.
Hi. Nice talk, Abhishek. What do you think of the role of internal brace? Do you use it in primarily or in division? And What are your indications?
So I'm not a big internal brace guy because once that I used, it threw a lot of synovitis, especially in the sinus tarsi, and I had to go in back and remove and revise. I've removed a couple of other guys' surgeries also, internal brace. So I think whatever is natural biology, I do that rather than internal brace. If I have to if I feel that the collagen is very poor, the scar is very bad, I harvest the tendon and I do a reconstruction. So I do biologic repairs or reconstructions rather than synthetic augments.
For people like us, tell us what is internal brace.
Okay, so sorry.
20,000 rupees earring.
Sir, it is basically a fiber tape. Okay, the reason, especially the reason we talk about it is if your tissue is already too lax. So if you have a 7-10 millimeter drawer like I have, he has, we all lose ankle anyway. Now when you're trying to tie it up, that repair, so when you're using your gauls and your modified gauls, you're using your tissue too tight enough which will again become lax. So how can you use a lax tissue which will become lax to have a stability? So that is where I have my indications for using in those people who are already very lax. So if you do both sides, you will get the 20-degree tilt, but one is symptomatic, one is completely asymptomatic. So in my cases where I use internal brace.
So internal brace is like a suspender. You know the suspenders which used to hold your pants up. Even though you have a belt, you have a suspender. So it's just like that. No. So that's a fiber tape. It is synthetic. So biology, collagen stretches. So again, but because it is synthetic, there could be a foreign body reaction, seroma, and plus that area is small, unlike the knee joint where actually the data is more extensive on such tapes, because both the joints, ankle is dorsiflexion, plantarflexion, subtalar joint is inversion, eversion, and some rotations. So if you put a tape which is subject to all three axes of rotation, there would be some foreign body reaction. That is my take on it. Yes, sir, please. No, elbow, correct. That's a hinge joint, correct. Yes.
So,
Plantar flexion, sir.
any more?
Often these grade 3 tears are associated with bone edemas or chondral injury or something. So your take on this and the weight bearing protocols for grade 2, grade 3 things.
So if there is a chondral injury, so in my head, it's definitely like a very high velocity first episode, or it's a multiple, like a recurrent instability. So if there is a chondral injury, I don't want to take any chances in my patient where I would subject him to maybe one more twist. So my threshold to repair chondral injury patients is very low. I will repair them quite early. Weight bearing in a grade 2, 3 depends entirely on patient's pain threshold. So if patient is comfortable, I'm happy to load because weight bearing elicits better cartilage blood supply, range of motion elicits better blood supply.
So what do you do in that period? And you are allowing them just beginning of it?
So beginning of weight bearing will be an ankle stirrup with a shoe, not with a chappal, because I need a heel cup to hold my stirrup and not let my hind foot slip out.
So things to consider. Sorry, we take all the questions after the session is over. One quick last question, please.
So what is to consider when you are going for a repair or a reconstruction? Things to consider.
Things to consider, I think we just discussed. If it's a fresh injury, I would repair. If it's
time frame for a repair.
Time frame is, I'm not worried about the time frame. It's if it's a repeated instability, I would still give first chance for a repair because they have all worked well, I think, in literature and in my hands. Reconstruction is a big surgery, like, screws here, there, implants, bone tunnels, all those things. So primary first timer, always reconstruction in my hands.
So time frame is not to be considered.
Primary repair in my hands, sorry.
Okay, thank you, Abhishek.
Thank you very
much. It was
much.
a wonderful lecture. May I invite Dr. Shyam Thakkar for his next talk on the deltoid and the syndesmosis.
Good evening all, my respected teachers and my dear colleagues. We all know that couples are difficult to understand. This is a different kind of couple where both have equal role in stability, but if one is injured, the other is also would be injured, so we have to look for it. So let's talk about the anatomy first. It's deltoid, commonly referred as the medial collateral ligament, spans out from the medial malleolus up to the tarsal bones, creating a delta shape, hence the name. It has superficial and the deep layer. The superficial consists of tibio-navicular, tibio-spring, tibio-calcaneal, and pointer, and the superficial posterior tibio-talar. The deep layer consists of two ligaments, anterior and posterior tibio-talar ligament. It crosses only the ankle joint and not the subtalar joint. It prevents lateral displacement and external rotation of the talus. Okay, so the function, it attaches medial malleus to the tarsal bones. As we saw, it is a primary medial stabilizer. It restrains valgus tilting and anterior translation of the talus. It is a most prominent restraint against lateral translation and provides stability to the tibio-talo-calcaneal joint complex. The syndesmosis is important to consider it as a joint with a bony ligamentous complex. It has both articular surfaces on facets on the both tibia as well as the fibula, and it can extend up to 3 centimeters above the ankle joint. So although bony congruity, majority of the stability is with the ligaments. So the AITFL, PITFL, and ITFL. Earlier we spoke about the ATFL. This is AITFL, in anterior-inferior tibiofibular, posterior-inferior tibiofibular, and the intraosseous tibiofibular ligament. So this is a bony anatomy. It has a convex surface on the fibula and concave on the tibia, a triangular surface which attaches. The tibial part is concave like we saw. The important bony landmarks, one is the anterior tubercle, which is the caput tubercle of the distal tibia, and the posterior tubercle, the Walkman tubercle. The fibular part is, like we spoke, is a convex triangle with distal anterior tubercle as the Wagstaff Lefort tubercle. And the last but not the least, the tibiofibular contact zone is the most distal part of the syndesmosis. It acts as a guide during fixation or during syndesmosis reconstruction. So biomechanics, if we see, the AITFL is a primary restraint for fibular external rotation. PITFL is posterior, so for posterior translation. The intraosseous provides lateral resistance to lateral translation, and the deltoid, which is more important, which prevents further lateral translation. So if we consider the stance phase of the gait, the fibula rotates normally 2 to 5 degrees in externally and translates 1 to 3 millimeter posteriorly. If we consider the graph, we see with the intact syndesmosis and the deltoid, the rotations are normal. But if both of them are torn, the rotations increase. So it is necessary to repair or to address both syndesmosis as well as the deltoid. So Harris et al. Concluded the stability 35% is by AITFL, 22% is by intraosseous, and rest 43% is by the PITFL. Xenos et al. Had studied, they transected the syndesmosis sequentially, and they found that after AITFL there is 2.3 millimeter increase. After intraosseous membrane, there is additional 2.2 millimeter, and with PITFL, there is total increase of almost 7 millimeter. So here are some graphs about the anterior medial, posterior medial lateral drawer. You can appreciate with intact syndesmosis and with either syndesmosis or deltoid, and with both. And if we repair both, almost the translation comes back to the normal. So let's talk about the mechanism of the injury. Most commonly it is eversion or external rotation with the dorsiflexion and foot in pronation. Pronation foot is more important. So I know it's a pretty horrible injury. This commonly happens don't happen in sports in India, but yeah. Sometimes there is a combination of inversion and external rotation. So at that time, the lateral structures are also involved. Chronic may be associated with posterior tibial tendon dysfunction. So let's understand the Log-Hansen classification, which many of us, even I had a difficult time to understand. I tried to make it simplify. So the first word is the disposition of the foot, is it pronation or supination, and the second word is the force acting, adduction, abduction, or external rotation. So if we see the first, supination, adduction, the injury starts from with the supination of the talus, first the fracture or transverse fracture of the fibula, following by the vertical shear fracture of the medial malleolus. Deltoid is less likely injured in such cases, but it may be. Secondly, we speak about the supination external. When the foot is supinated, the primary injury is the AITFL is torn first, followed by the spiral oblique fracture of the fibula. Most commonly, it is the Weber type B in supinatory external rotation, and followed by PITFL or posterior malleolus, and last but not the least, the deltoid. So it is important to look at the ring concept of the ankle, which is either from the medial to lateral, lateral to medial. Pronation, abduction, pronation starts with the medial side first and goes to the lateral side. Again, the pronation external rotation, it starts with medial. So pronation starts with medial, supination starts with lateral. So pronation external rotation, there is a deltoid injury first or a medial malleolus, followed by AITFL, fracture of the fibula, and followed by posterior malleolus. So we'll just some special tests about the deltoid: eversion stress test or talar tilt test, valgus test or external rotation test. For syndesmosis, there are multiple tests which are in theory, which are some of them are intraoperatively. So the clinical test, external rotation test, Cotton's test, crossover leg test, squeeze test, and one leg hop test, and fibular translation test is hook test is of intraop findings. Some X-ray findings which I guess would be covered in next lecture. So isolated deltoid injuries are very rare, only 5%, and complete disruption of deltoid is associated with injury to the syndesmosis. Out of them, AITFL is commonly injured. So like I spoke, pronated and supinated foot, pronation external rotation starts with the medial side, goes to the lateral, and following the type C fibula fracture, and supination external rotation starts with the lateral side first, AITFL, followed by fibula and the medial malleolus. So in injuries, external rotation, abduction, both deltoid and syndesmosis can be injured. So this was one case where we repaired the posterior malleolus, but still there was opening, and with the hook test there was no widening of the syndesmosis. Then we went on medially and we found that the deltoid was injured. So after repair, so it is important to look for both syndesmosis as well as deltoid. So take home message, deltoid and syndesmosis are closely associated. It is important to understand the mechanism of injury before going in. There should be a high suspicion for syndesmosis injury in bimalleolar fractures, and weight-bearing X-rays are important to identify hidden injuries. Thank you.
Okay. Any questions?
What are these injuries these footballers are having? They fall down with so much of pain, and as soon as the yellow card is shown, they become normal.
Yes, sir.
It's supratentoral injury, sir. There's no retinaculum or anything.
This was just to add some. So vast difference between a American football injury and a normal football injury.
So I think this was a tough topic to cover. Take home, I think, as my colleague Pradeep always says, there are two things. One is a talar shift and one is a talar tilt. So talar shift happens or is more likely to tell us about the syndesmosis, when you pull out, hook test and everything. And when you fix the syndesmosis, and if you still have a talar tilt, as Shyam showed, you should always not miss the deltoid. So that's the importance, and these are very important injuries, especially in a trauma scenario where we come across ankle fractures.
Any more questions? Okay, we move on to the next lecture. Thank you, Dr. Shyam. Okay, there is a poll. Yeah, just answer the poll in the delegate section. It's on there is an X-ray which is posted. WIROC delegate section. Okay. We move on to the next lecture by Dr. Soumyadip Dutta, Syndesmosis and Instability.
Thank you, Chairpersons, organizer, for giving me this opportunity. So I will talk about the syndesmotic injury, though it has been covered previously by the anatomy and the biomechanics. So I'll just straightforward go to a simple X-ray which has been seen in an ER, patient has been sent home. But when we take the patient, evaluated the patient further, we have done the fluoroscopy. It is like an ankle sprain as diagnosed in the ER, but it was not so. So when we done the fluoroscopy at the operation theater, we find there is an opening is happening, and it is not as simple as a simple ankle sprain. So then the question comes that all the ankle sprain are not simple. About 1/5 of this ankle sprain, we call it higher ankle sprain, are the syndesmotic injury, which we often miss in our day-to-day practice. And these sprains take longer recovery time than our normal ankle sprain. So this ligament anatomy I will not go in because it has been previously covered. The mechanism as has been covered is a forceful external rotation and abduction. It just widens up the ankle mortise. So regarding the biomechanics and importance of syndesmotic, it's just hold the tibia and fibula together. It resists not only the axial, rotational and translational forces. So a lot of forces are acting around the syndesmotic, and it's not a static joint, it's a dynamic joint. When you walk, it's just widen up 1 to 2 millimeter. And deltoid and syndesmotic having a role to play together. Even a smaller amount of 1 mm shift in laterally significantly increases the joint pressure. So it is always important to reduce your joint and look for the syndesmotic injury. So clinical evaluation is always important. You have to take the history about the injury, whether it has a forceful external rotation and dorsiflexion, whether it is a contact injury or a non-contact injury, acute or chronic injury, and the evaluation of the patient. If there is a severe edema, ecchymosis and antalgic gait, this always indicates towards a syndesmotic injury which is often missed in our OPD or clinic. So X-ray is always important, and you have to go for an AP lateral mortise view, and if possible a stress X-ray. If the patient can bear weight, you can take a weight bearing fluid. And if you are in doubt, never hesitate to take the patient for a fluoroscopy in the ward. You have to see about the 1 centimeter above the plafond. You have to see for the tibiofibular clear space. You have to see for the tibiofibular overlap and also the medial clear space. So like this X-ray, when these all things are gone, the tibiofibular overlap is gone, the tibiofibular clearance space is increased, the medial clear space has increased. There is something syndesmotic is being injured in this case, obviously. So further evaluation can be done. MRI is always sensitive. If you are diagnosed a ligament injury, MRI always show you. And CT scan is nowadays ankle fracture. We almost routinely go for CT scan, and to see the position of the fibula, we can diagnose whether it is sitting properly on the incisura or not. We can diagnose easily the syndesmotic injury. Then if you are a scopy surgeon, this arthroscopy is always held there a paper, because this subtle syndesmotic injury, your scope, you put on the scope, and if you have 5 mm standard probe, if it is inside, you can inside between your fibula and the tibula, that indicates there is a injury there. So this is another way, this both diagnostic and therapeutic. And regarding the fixation method, when there is a medial joint space opening more than 1 mm in a stress view, clear space is more than 5 mm, and the overlap is less than 5 mm, you have to go for fixation. You have to evaluate the patient both in AP and lateral view. In lateral view, you often miss the fibula has to be on the center, on the tibia, like this X-ray. So in a fracture scenario, your fracture has to be fixed anatomically. There is no doubt about that. You have to restore the fibular length. If you have a posterior malleolus fracture, you have to fix it. Then you have to see for a stress X-ray, stress fluoroscopy, and if you have doubt, you have to go for fixation. So cotton test, which has been routinely described So cotton test has been, there is a 3 ways of doing a cotton test which has been described in recent literature. One is to hook the fibula, another is to pull the fibula, another is to lever, because there is always a chance of sagittal plane translation of the fibula over the incisura. So this is the way you have to check if you are not missing any syndesmotic injury. And regarding the screw technique, there are multiple literature are coming. This closed reduction is not the way now, because a lot of times we malreduce the syndesmotic during our closed reduction, internal fixation. We have to go for open reduction. And regarding the number of screws, you can go for 1 or 2 screws. You can use 3.5 or 4 mm, 4.5 mm screw. You have to be 2 to 4 centimeter above the joint line, and you should not be parallel. You should be from sidely posterior to anterior angulation. Your screw should be there. It should be parallel to the joint line. You have to hold at least 3 cortices, and ankle should be in the neutral. Previously, there was a thought that you have to be dorsiflex the ankle because you will load the joint more. You have to be neutral position. And then regarding there are fixation techniques, there are screws routinely used, 3.5, 4.5, it depends, whatever you are comfortable with. There are newer devices like button fixations. Now anchors are also coming for the repair, and some of people have done the autografts also. So regarding, I just go to the recent trend was button fixation, because it doesn't need a removal. It's a dynamic fixation. It eliminates slippage, stronger than screws biomechanics, as the study said, and the chances of screw breakage. When you give the weight bearing, there is always a chance of screw breakage, but it has its own complications. So the take-home message is always clinical evaluation is the most important part that diagnosing the syndesmotic injury. Never hesitate to go for stress radiograph or fluoroscopy to unmask the injury, and open anatomical reduction is the treatment of choice, and fixation with screws or button, whatever you feel is best in your hand. Thank you for the organizer for the opportunity.
Yeah, nice talk. I think we don't have time to questions, sir. I will ask for the next topic. Pradeep Moonot.
Thank you very much, Abhishek, for inviting me and the organizers. So my topic was fan that cools the heel. Now, what does that mean? Actually, and a lot of people asked me in the earlier morning. Actually, I'll be talking on chronic deltoid injury and reconstruction, the fan that cools the heel. It's an interesting talk, and thanks for giving me this talk, Abhishek, and I hope I can do justice to it. So let's start with the case. 24-year-old male, pain and giving way sensation because of a twisting injury. This was almost a year before he presented to me. An MRI was done locally which showed a deep deltoid ligament tear, CFL tear and ATFL tear. He was definitely advised surgery, but because of his whatever commitments, his reservations, he did not opt for surgery. 6 months later, again have a giving way sensation, twisting injury on the same side, and had more pain and swelling. And that's when he came and saw me. On examination, he had a slight excessive valgus on the right side compared to the left side. You can see there is a slight medial side prominence. The medial malleolus looks prominent and a bulge seen there as well. Draw test was positive and he was unable to do a single heel leg raise. Now look at the difference between the MRI of the top and the bottom. November 2020, May 2021. Look at that. It's okay, deltoid injury is there, but if you look, what is there? The spring ligament which was intact in November 2020, in May 2021, he is showing there is thickening with interstitial edema consistent with a tear of the spring ligament. So we'll come about what do we do for this patient now with a chronic deltoid injury, with spring ligament gone and with the lateral ligaments gone as well. So a bit of anatomy on, I know it's been touched upon, but still I think it is an important topic. You need to understand it's a superficial and a deep. The superficial has 4 parts to it: the tibio-navicular, the tibio-spring, the tibio-calcaneum, and the tibio-talar, the posterior. That's a superficial ligament. It's a fan-shaped ligament. Inserts onto the sustentacular talar, and it almost continues along with the spring, and I'll come to what is spring as well. And the deep is a D, ATTL, so anterior and the posterior, deep, ATTL and PTTL. Now spring ligament again has a various bundles to it. I don't want you to remember it. I don't remember it. But the key thing is you need to understand this is the medioplantar oblique ligament. Now, why is it important? Because it acts like a hammock which supports the talar head. If you do not have a spring ligament, or if it is stretched out or torn out, you're guaranteed that the patient will have a hindfoot valgus and a guarantee that the patient will have a pes planus. There's no question asked about. So it's a very, very important ligament. Now, looking at the literature on what happens if you have a deltoid instability or a spring, now a lot of literature, but usually in flat foot, and you have to see that multiple bone tunnels have been used, multiple allografts or autografts needs to be used. So these are complex procedure, cumbersome, and needs multiple bony tunnels. So, coming back to my case, now he is a young chap. He is this instability. What do we do? If you look at it, as we already said, compare it always on the normal side. Normal side here, there was no tilt. You can see here the tilt. So, the lateral side instability and medial side instability as well. I did an ankle arthroscopy for him, and you could make out the ankle, the talus just does not rotate, or varus or valgus, it rotates into the mortise. That is important to understand. So a plan was made. This is my handwriting, a diagram. What would I do for him? So opened up on the medial side. I can't appreciate much, but the medial deltoid ligament was relaxed. It was raised from the medial malleolus. Sustentaculum tali was identified, a wire was put, that is a drill, so a whole arthrex, the whole ATFL or internal brace set comes along, which has wires, drill bits and everything. That's the whole set which is opened up, a swivel lock, a 3.5 swivel lock going into the sustentaculum tali, and then a fiber tape was passed through the navicular tunnel, and finally the whole complex was repaired. And on top of that, the whole superficial deltoid layer, which was taken up from the medial malleolus, that was repaired using a 5 mm titanium anchor with 4 strands. So that was repaired. On the lateral side, of course, there was a whole ATFL and CFL was gone. That was repaired with a modified brostrum. And these are the videos after a year where he can do a single leg hop. He can do everything, raises back to his normal activity. So this was written up, so that's called as a quadrangular construct. Just a few seconds to spend on. That's your medial malleolus. So this is your tibiocalcaneum reconstruction done. That is your spring ligament reconstruction, goes through the navicular, and this part almost mimics the tibio-navicular and the deep ATTL type of. So reconstruction with an internal brace. Second case, which a poll was already been put up on the WhatsApp group. 52-year-old injury, 52-year-old male injury to the ankle joint. Unfortunately, so these were the options listed, and most of the people have given it right, where they have said fibula fixation with syndesmosis with a deltoid. Few people have mentioned only fibula fracture fixation or fibula with a syndesmosis fixation. Unfortunately, this chap came to me 4 months later with still pain while walking, and he's noticing that he had already flat foot, but he noticed that the right side, which was the operated side, is going more further in valgus than the left side. And this is the prominence. He came, I said, I can't walk. Okay, and you look at that X-ray, that's not normal, that's the talus going outside. I will take a few seconds more. And you see this MRI was done. Look, there's no deltoid at all. The whole deltoid is just gone. Okay, so we did that, and here we opened it up on the medial side. This is like a takla medial malleolus, I would say. No offense, nothing on that. You see that? It was completely denuded, and that's your flimsy deltoid, which is stretched out more distal than what it is. Sorry, Rajiv. Okay? And that's the whole deltoid being lifted up. You laughed first. You laughed first. That's why I had to point to you. Sorry, sir. And then you had a medial malleolus going from here, one screw into the one swivel lock or a limb going into the sustentaculum tali, and one into the neck of the talus. And you can see here on the left side was pre-op, post-op, after reconstruction. Okay, so he's done well. Just a last case for a few seconds more, sir. Last case, 48-year-old lady, adult acquired flat foot, as I was telling 2 days back. It's not just pes plano valgus. Adult acquired flat foot, pain in the ankle, dried insoles, and had an MRI done. Showed, yes, all the features are tip post tenosynovitis. But look at this, deltoid ligament, edema, strain, stretch. So you need to address that. Again, had the same reconstruction. That's your tibio spring ligament, and that's your anterior limb. Had the reconstruction done like that, like a quadrangular. This is a 2-year follow-up. Luckily, she just came last week, and you can see how she has a more arch on the operated side than the other side, and she is able to do her single leg hop, everything. She just came, said, I don't come to Surat, so I just want to just come and see how things are. So in summary, always assess for deltoid injury. It is easier to do a repair, open it up, put an anchor and repair it, than to have missed or chronic tears, which leads to damage to the other ligaments, and especially the spring ligament, which is a very, very important ligament, as we saw in the case 1. And it becomes a very difficult situation to sort out these chronic deltoids, and need a hell lot of planning and expertise required. Thank you so much.
Thank you. Thank you, Pradeep. I have one question. How late you operate primarily, repair the deltoid ligament?
So, so this chap, the second case came 4 months. As soon as he came, I identified, I chose, anytime they come and if they have symptoms, they need to be repaired. So repair plus minus reconstruction, both on the table.
Only repair?
Only repair, I would say 2 weeks. Beyond that, you are not looking at, you won't get that with the anchors.
So one more question.
In case 2, Dr. Moonot, in case 2, how about fixing the fibula and the deltoid repair without handling directly the syndesmosis?
So there are 2 papers in literature, and especially from UK, who have suggested doing that. You could do that. That's not a problem. Means you need to have that courage of conviction to do it. You can do a fibula, you can do your deltoid repair, then assess it, and if you think that the syndesmosis open up, you can always do a syndesmosis. So there is no, the point is there is no right or a wrong answer. The point is assess your ankle stability properly. So it's a sequential thing to do. So you could do a fibula, open up the medial side, do a tight repair of the deltoid and do it. And what they are saying is syndesmosis usually acts like a surrogate repair. So you do your fibula and do your syndesmosis, and you say, okay, I have a 2-degree tilt, I'll accept it. That's your surrogate repair. That's fine.
That was a question.
Sir, what is your rehab and weight bearing protocol after the repair and reconstruction?
So both repair and reconstruction, they go in 4 weeks in cast. After that, they can start moving the ankle. Cast is out, remove the cast, mobilization, ankle ranger movement exercises. They go in a walker boot for at least 4 to 6 weeks more. After that, just goes with a brace. So in-house, so indoors, they can walk without any support. Outdoors, especially, if it's an uneven surface, give them a brace. That's all.
Thank you, sir.
Thank you.
I think, thank you, Pradeep. You just didn't do justice, but you aced the talk. Thank you very much.
Thank you so much. Thank you.
I knew I had my best gun firing in the end.